Well, hello, and thank you for joining part two of treating patients with antihypertensive medications. So we were talking about ARBs, and ARBs are the angiotensin II receptor blockers. So I was saying that they're very similar to the ACE inhibitors. So if you remember how ACE inhibitors work, then this is very similar. But we know that ACE inhibitors stop the production of angiotensin II. ARBs block the action of angiotensin II. So either way, angiotensin II is not able to exert its effect, either in ACE inhibitors or in ARBs. Um, the ARBs block that angiotensin II receptors in the blood vessels. So what's going to happen then? If angiotensin II can't do its work, same thing, it's going to vasodilate. It's going to open up those blood vessels. And by blocking the angiotensin II receptors in the adrenals, the ARBs decrease the release of aldosterone. And we remember what aldosterone does. And so by decreasing the aldosterone, we're going to increase the excretion of sodium and water, right? Because remember, aldosterone's job is to say, hey, I can fix this low blood pressure problem and keep the sodium. But we're doing the opposite of that. So it'll get rid of sodium and water. Um, Different than the ACE inhibitors, the ARBs do not increase bradykinin. So you will not see that same cough that you see in ACE inhibitors. But again, you will want to watch for any situation that might lead to a drop in fluid volume, like excess sweating, vomiting, diarrhea, dehydration, because these patients are going to be at much higher risk for low volume, hypotension. So you want to watch out for that. Also, this drug can also cause high potassium. So we're going to be watching things like telling patients that they should avoid salt substitutes that have potassium in there, increasing foods that have potassium. We're going to tell them to be careful about this. We don't want increased potassium. And then also this drug can cause fetal harm. So we're again telling our female clients to use contraception. Excellent. All right, moving on then. The next classification of medications that we're going to be talking about is the calcium channel blockers. And these end in the suffix dipine, D-I-P-I-N-E, such as nifedipine. But you are going to be learning about a calcium channel blocker that works a little bit differently than some of the other calcium channel blockers. And this medication is called diltiazem. And what's happening in the calcium channels in the heart? If you look at figure 42.4 in your CARCH text or at the bottom of the screen there, it also has that. What's going on inside the heart? Now remember that the heart has its own cells. The heart have these myocytes. And within the cells, within the heart, how does the heart work? How does it function? It's an electrical activity, right? So if you look at an ECG, we see the electrical activity of the heart. And how does that electrical activity happen? It happens from ions. And particularly calcium is so important for the proper functioning and electrical activity of a heart. And cardiac cells need that calcium, those ions, to make the heart contract. So diltiazem is a calcium channel blocker. So it's going to inhibit that movement of the calcium ions across the membrane of the cardiac and arterial muscle cells. And so that's going to lead to depressing the impulse and leading to a slowed conduction and decreased myocardial contractility. And that's the same thing as the strength of the contraction of the heart. So it's going to cause this dilation of the arterioles, which will do what? You're right, it'll lower the blood pressure and it'll also decrease the myocardial oxygen consumption. So by blocking that entry of calcium by these calcium channel blockers and reducing that electrical conduction within the heart, remember, it decreases that contraction, that work of the heart muscle. and dilates the arteries, dilating the blood vessels to dilate the blood or to lower the blood pressure. So the heart doesn't have to work as hard, because when a heart has high blood pressure, it's working so hard against this high pressure. So we want to tell the heart and the arterioles to just relax. It's okay. So this drug is used for hypertension. It's also used for, as you can probably imagine, angina or angina. So again, this drug is telling the heart to relax. You don't have to work so hard. You don't have to squeeze so hard. You don't have to use as much oxygen. But when blood pressure is decreased and the heart doesn't have to work as hard, it's not going to use as much oxygen. So when we're looking at the different effects of this medication, the heart may slow down. So you'll see possibly a little bit too much effect, right? Whenever we're looking at adverse effects, you always think about, well, what's the action and what would too much action be? So we're looking at hypotension again, of course. So again, telling patients to get up slowly, watching out for that orthostatic hypotension, dangle their legs at the edge of the bed. And also, so the slowing of the heart, we may notice that you, again, we're going to talk about heart failure in another video, but think about things are slowing down. You may see edema, and especially the lower legs, heart rate may decrease, constipation. So we're going to tell patients to increase their fiber to kind of combat that constipation. Remember, no grapefruit juice because it can cause a toxic level of calcium channel blockers. And also, since we're messing with the electrical activity of the heart, we can cause patients to go into a heart arrhythmia, a heart block. So definitely be aware of that. All right, the next classification of medications that we're discussing is called the renin inhibitors or the L-askyrin. So this is also going to affect the RAS system, the renin-angiotensin-aldosterone system, but it's going to actually block, it's directly inhibiting that renin. The very first, right, where the kidneys release that renin saying, hey, I know there's a problem, the renin inhibitors are going to directly inhibit that renin. So it's going to lead to a decreased renin activity, and that will inhibit the conversion then of angiotensinogen to angiotensin 1. And then ultimately there's a decrease in angiotensin 2, which is the vasoconstrictor. So again, this inhibition of this RAS system is going to lead to decreased blood pressure, also decreased aldosterone. So we're going to see decreased sodium reabsorption again, because it's blocking that renin-angiotensin system. Aldosterone will not be released. So there is that risk of hyperkalemia again. So we're going to, again, monitor our monitor for high potassium. We're also going to be especially careful about patients who are already at an increased risk for high potassium, such as a patient who is on a potassium-sparing diuretic like spironolactone, because that's going to keep potassium. So if you have two medications that are keeping potassium, then your patient's at even a higher risk of high potassium. So we need to monitor that as well. Also, we're monitoring for intake and output, daily weights, making sure the patient doesn't feel faint or experiencing any syncope. And again, it is dangerous in pregnancy, so we are going to have patients use contraception. Next classification is the vasodilators or nitroprusside. Now, this is for severe hypertension. These are in emergency situations. This is not a medication classification that'll be used if a patient's blood pressure is 135 over 92. No, this is going to be hypertensive crisis. This medication, nitroprusside, is given IV, and it is going to act on the smooth muscles, right? So think of, again, that artery as a garden hose, and it's going to not constrict it. It's going to vasodilate, open up that blood vessel and cause a decrease in blood pressure. So some of the side effects you may notice are headaches, chest pressure, palpitations, sweating, nausea, vomiting, and abdominal pain. The next classification of medications is the alpha 1 blockers, or prazosin. And you remember these classification of drugs from the neuro section, where we learned about the adrenergic antagonists, or the alpha blockers. So we know what happens when the adrenergic system gets an agonist or increased. It will increase the heart rate, increase the blood pressure, but this is a blocker, so it is going to decrease that fight or flight. And remember, alpha artery, the alpha 1 receptors are more on the blood vessels, arterioles. So it is going to, again, act directly on that alpha 1 receptor. It'll decrease that vascular tone, increase that vasodilation, and decrease the blood pressure. And last classification of antihypertensives that we're going to talk about are the beta blockers. Remember that these end in OLOL, and remember atenolol is a beta 1 blocker, and remember one heart, beta 2, 2 lungs. So the beta 1 is going to affect the heart. So atenolol is the beta 1 blocker that is used to treat hypertension, and it blocks vasoconstriction. So it will decrease the heart rate, decrease that muscle contraction, and it will tend to increase the blood flow to the kidneys, leading to a decrease in the release of renin. And we all know what that does now. These drugs do have many adverse effects. They're not recommended for a lot of different types of patients for hypertension, but they are quite often used in step 2 treatment. In some patients, they do work very, very adequately. And that is the end. So thank you very much for joining the videos on antihypertensive medications. And the next video will be on heart failure. Thanks.